next we're going to have Dr. Florian Eichler, and he will be talking about advanced cerebral ALD. Thank you, Dr. Eichler.
Great, thanks, Elisa, and grateful to be here. And what an amazing conference! And I take a lot of strength and inspiration from hearing everyone speak, particularly the patients and families. I think it's a constant reminder of why we do what we do. And I will say, coming together as a community is what often helps address some of the hardest questions. I think earlier on we heard about the challenges and follow-up for MRI, and Ali Fatimi saying, you know, you got to also do this for your loved ones and for the community around you, and nothing could be more true. And I will say that today we were just able to enroll somebody in the Calyx trial, and so grateful that there are options for this family. So what I thought I would talk about today is vision in advanced cerebral ALD, and I entitled this All the Light We Cannot See, based on Anthony Durr's book. But I hope it sheds some light on aspects that we often do not talk about. Here are my disclosures. I'm going to start with a case of a 9-year-old boy with progressive auditory and visual processing problems, along with memory and gait difficulties. Over the summer, parents noted he responded differently when spoken to. It was a question of whether he had hearing loss. He got lost even when parents were very close or within eyesight. He had slurring of words, difficulty with short-term memory, and his MRI showed this classic lesion of cerebral ALD. His exam on finger, nose, finger shows you the difficulty he was having with visual processing, and he was an amazing young boy who really participated without any frustration or any resistance to the exam. And I think it shows you that there's a real problem here in visual orientation, processing, and the number of different symptoms I've reported here also show you that these the visual symptoms also contribute to other problems as well. So he was hesitant to actually, after some time, step out of the house and walk, in part because of his visual processing problems. So what is it that we mean when we talk of visual processing, and what is affected in cerebral ALD? Often when we speak of vision, we think this is about the eye, and we attribute vision solely to the eye. But this is really only the anterior visual pathways that the eye is capturing, whether lens and retina, that are important for visual acuity. And there's much more to vision that reaches here from the optic tracts down into pathways within deep parts of the brain that we call the thalamus, where there are relay systems such as this lateral geniculate nucleus, where then information is passed on to the visual cortex, which is here at the back of the brain. And I just want to point out that the classic lesions in cerebral ALD are in exactly this posterior back part of the white matter that connects to the visual cortex. So, not surprisingly, visual processing is a problem in cerebral ALD. We've had the good fortune of leaning on an old institution within the Boston area, the Perkins School of the Blind, that has been around for close to 200 years and has helped generations of children with vision problems. And the vision loss has been recognized as not being solely due to visual acuity, but being really far more complex than this. And you can see here picture of Ellen Mazel, who was an expert in visual processing, and really raising awareness around the importance of the brain, not only of the eye, to vision. And this has given rise to the term cerebral or cortical visual impairment, and really highlights the fact that visual disturbance is not only due to the eye and the anterior visual pathways, but involves so many other parts of the brain. And this is luckily now an institution within Perkins that is helping children beyond visual acuity and visual field defects. So I just wanted to list some of the landscape of cerebral visual impairment and point out that among the many different causes for vision problems in general in children, the visual perceptual abilities or the cognitive visual processing looms very large. It's close to 90% as reported out by Perkins and other institutions. And they use here two different terms to describe the cognitive visual impairment. They use a term called lower order visual problems and higher order visual problems. What is meant with these terms? So lower order processes are those of visual acuity, so how well focused your vision is, your visual field, and whether you have any field defects, contrast sensitivity, and the movements of the eyes, and so oculomotor findings. This is in contrast to higher order processes that are those of complex visual, spatial, and object processing tasks. So when we send off for neuropsychological testing, that is often the kinds of perceptual reasoning that we are assessing there. So we started a project looking at our MGH cohort a few years ago, and we decided to characterize the visual processing deficits by looking at a retrospective chart review done between 2005 and 2020, and looking at signs and symptoms of visual dysfunction in cerebral ALD, and then also had a prospective virtual reality-based functional assessment together with Lotfi Merabet at Mass Eye and Ear, where we recruited both cerebral ALD patients from our clinic as well as controls who didn't have any history of ophthalmic conditions. So just to highlight some of the findings in this cohort, we had 89 cases of cerebral ALD in our chart review. It's important to note that when we separated out lower order deficits and higher order deficits, lower order deficits were the kinds of things we could assess during the neurologic exam in clinic. Higher order deficits, however, required neuropsychological testing. So there were only 51 of these patients that went through neuropsych testing. So one of the first things to note is that lower order deficits occur in children with even less scores, so children that have a less score lower than 3, 50% of them had lower order deficits, higher order deficits only in 36% of patients. And as, not surprisingly, as your less score increases, the percent of patients with both lower order deficits and higher order deficits increases. But there even are 20% of patients who do not have here any higher visual processing problems. Next, we looked at how things are before and after bone marrow transplant, and we only had, I think here, one patient who was about to go through transplant normal, but after transplant, we still saw significant amount of both lower and higher order visual processing deficits. Interestingly, adult age did not seem to make a difference. Both children and adults with cerebral ALD both displayed lower and higher order deficits to a similar percentage point. I just want to present a few cases to illustrate some of the challenges in talking about visual impairment and the relationship to the visual pathway. Because at first it might seem like, well, as long as you have a lesion within these pathways, you should have a corresponding structure-function correlation and impairment of vision. As shown in this case, here you have a transplanted boy with cerebral ALD, 1 month post-bone marrow transplantation with less score of 8.5, involvement of visual pathways. And you can see here on T2 weighted imaging these posterior lesions that are affecting here lateral geniculate nucleus, optic radiations, parietal occipital pathways. And you can see here, these are exactly the areas that connect to the back of the brain where visual processing in the cortex occurs. To Bill's earlier question about cortical involvement in seizures, just a little side note. So we've actually looked carefully on brain autopsies for demyelinating lesions in cortex, and we've not seen that. So it's quite different from MS. So similar to the seizure question, I think we can probably take that off the table here for the cortex with vision problems as well. Here, however, is another case where we have involvement of the visual pathways and the posterior parts of the brain, lateral geniculate again involved, as well as the optic radiations. But in this case, there is no visual impairment despite the prominent visual pathway involvement. So some discordance here that arises, and telling us that we have to be careful in drawing conclusions from the site of the lesion and deducing that we have to necessarily see deficits in function. And here we have a case of deficits in visual motor integration, visual spatial perception without visual pathway involvement. So in this case, the posterior parts of the brain and optic radiations are fine. Lateral geniculate, remember that's the part in the thalamus that information from the eye is relayed through. That's all completely fine. There are no lesions here, but we find lesions here in the front of the brain. And in this case, it is interesting to note that on neuropsych testing, there was prominent deficits in visual motor integration and visual spatial perception, speaking probably to the fact that some of this information needs to be also processed through the anterior executive functioning happening in the front of the brain. So just to summarize some of this right here, posterior predominant lesions, as we classically see in cerebral ALD, 60% with lower order deficit, 57% with high order deficit. But very interesting, with the anterior predominant lesions, we only see 18% lower order deficits, but we see 50% of higher order deficits. Again, keep in mind, these are the kinds of visual motor integration, processing, perceptual reasoning that may require the frontal networks. So here, a listing of all the different kinds of visual deficits we found in our chart review. Most common were lower order deficits of eye movement abnormalities, what we call oculomotor abnormalities, nystagmus, saccades. So these are all descriptions of small eye movement abnormalities, decreased visual acuity, visual field defects, but then a whole host of various different higher order deficits that are seen in a number of patients. So how best to characterize those? And, one of the things we're thinking about is beyond doing neuropsychological testing, are there ways to capture some of the visual processing problems? And here we had the help of Lotfi Marabet, who has worked with virtual reality technology and was able to help us use tools from Mass Eye and Ear to do this comparative visual search performance in children with cerebral ALD. And here on a 27-inch monitor, the patients are asked to watch a video of a hallway in a school in which there are various people walking through, and they have to track the principal in the hallway. And then there's low, medium, and high density of people at different tasks in this virtual reality testing. And you can see that the patients with cerebral ALD do significantly worse than your age-matched controls. The ability to actually successfully identify the principal, the success rate is slightly lower, but importantly also the reaction time is significantly higher, speaking here to some of the problems that arise as you have lesions in the brain. And here, this again is just summarize the differences in success rate and reaction time in patients with cerebral ALD compared to controls. So just to summarize here, higher order visual deficits are common in all stages of cerebral ALD. Lower order deficits are readily measured in standard neurologic exam, while higher order deficits require neuropsych assessments. Visual impairment is associated with lesion size on MRI, but the correlation between the structure and function, particularly for the higher order deficits, is not entirely predictable. And we hope that virtual reality-based assessments will in the future help us measure and assess and follow symptom burden over time. I think cerebral visual impairment is a real problem for cerebral ALD, and something that we even must find the correct language to describe and measure. Often processing the unique higher order visual deficits related to spatial processing is also referred to as dorsal stream dysfunction. So dorsal stream dysfunction is contrasted with ventral visual stream. Just to describe the difference here briefly, once the information comes through the eye and is brought to the back of the brain, it is then processed either through this ventral stream or this dorsal stream. Dorsal stream is considered immediate, unconscious, visual attention, online, sort of vision in action, if you so want, whereas the ventral visual stream is recognition of objects, memory. It's what we might say is the offline version. There's different kinds of tests you can do to assess this, so we can look at pursuits and saccades, peripheral visual attention, crowding, but visual testing for the ventral stream is tests like contour detection, matching. Why does any of this matter? Well, it matters because you might take different strategies at rehabilitation and thinking about how to help patients as they are trying to cope with a changing visual world. For dorsal visual streams, you might avoid multitasking, declutter rooms, use visual guides, tactile support. Some of the advices I've heard is practice ball skills with a big ball. Ventral visual streams, on the other hand, you want to think about memorizing landmarks, wearing recognizable objects, so things that really help memory and help recognition. And this is still for us, I will admit, a learning process. We're very grateful to have people like Ellen Mazel at Perkins School, and Katie's always taught me a lot about attention deficit and how to also distinguish this from visual processing problems. So I just to put all that into context. Oh, so this unfortunately did not come through. Oh, maybe it did. I hope that some of this also incentivizes patients to say, maybe getting my brain MRI is helping understand what is happening in terms of my performance and putting it in relationship to the brain lesion load. Similar to what others have said today, we have challenges in follow-up for brain MRIs. This is work that Nicole Page and Katie Becker put together on 218 patients, boys and men that we follow and and require monitoring of brain MRIs for. And you can see that in the age range of 4 to 13 years, we do quite well. And then between 14 and 18 and above 18, we don't do so well. And there's challenges in follow-up and things that we're really trying to understand. But I think the first step is mapping this out and trying to visualize some of this data so that we can understand how to close the gap here. So now we have trials, we have opportunities, and we need to understand how we can incentivize compliance with monitoring and emphasize the importance of imaging surveillance. So I want to just close by bringing one more case, this one from Japan. This is a 7-year-old boy, reading and writing deteriorated. He lost his speech at 11, was bedridden, and tube-fed by 12 years of age. At 20 years, the family had the opinion that the patient had considerable residual visual capacity. And in this paper from Brain Development 2008, they went on to assess vision in this boy, comparing luminance and color contrast sensitivities. And I think it's an interesting question that many of us face who see advanced cerebral ALD boys. Is there complete cortical blindness? How much information, how much signal is still getting through? Is there residual visual capacity? And what they did is they used human optokinetic nystagmus to drifting grading. So this has to do with the fact that when you track a grid like this, you have a slow eye movement and a fast adjusting eye movement in the other direction, and you can track that and thereby find evidence for visual engagement. And they found in this boy that although there was severe deficit in color luminance and color contrast sensitivities, there was relative preservation of luminance contrast sensitivities despite the very devastating condition this boy was in. What I do want to emphasize is that we still do not know about residual visual capacity being useful for processing, and is the processing that's impaired really the big limitation here. So just to conclude, I hope I've shown you that there's a whole new field of visual processing waiting to be discovered, and rehabilitation strategies needs to take account of ventral and dorsal visual streams as therapeutic approaches differ. Even in advanced cerebral ALD, some visual capacities are still preserved, but the inability to process may still limit rehabilitation. So I don't want you to come away from this talk thinking, oh, there is some function and therefore there is awareness or processing possible. I think this is quite complicated, but as clinicians, it's an area I think that we continuously need to re-examine. We need to have a better understanding of vision in boys with advanced cerebral ALD to understand their perception of the world, and hope together we can make progress and come up with some measures that will shed more light on this. So thank you.
Florian, thanks so much for going into some of the details there of some of the overlooked, no pun intended, overlooked complications. Can you comment on some of the functional consequences, I guess, particularly in terms of reading, which is, a lot of these kids are at a critical stage for learning reading, whether it manifests as dyslexia or delayed reading on, skill development and so on. Especially, I think now we're transplanting mostly kids in the early stages, and I think maybe speak to, with that in mind in particular, so kids with early stage, maybe posterior onset disease, and any implications that these might have for reading, which would be It'd be a common question from families.
Yeah, so I think it's challenging. We do not really have enough data on this. I will say there's some interesting findings from the group in Minnesota that you can see visual processing and visual spatial problems even after transplantation in relatively early disease. So less score of around 4 or so. I think part of the challenge of assessing, dyslexia and reading and writing abilities is, are you talking about a relatively stable, disease and function versus the rapid decline that you often are seeing as these boys deteriorate in the active stage of the disease. So I think part of the challenge is our ability to relate to more static versus dynamic situations. So I think the easiest things will be to assess after stabilization through transplant different levels of lesions. I think the harder part is to answer what is happening in the dynamic progressive state. I do not think that before lesion onset there's a real difference in reading and writing ability in boys, just to be absolutely clear.
Do you think there's a role for visual evoked potentials in defining the problem and informing the intervention?
We have measured visual evoked potentials in various trials and also in the Bluebird trial, and while there can be abnormalities seen, I think it's similar to what we've seen with somatosensory evoked potentials in adults with AMN, that there are abnormalities, but they don't necessarily track the progression of symptoms over time. But again, I will say these are things we need to look at again with more sensitive techniques over time, but that would be my first assessment. Thanks for having me.